Thank you for the organizers. Is it clear? Can you hear me?
Yes, yes.
Yeah. Just a second.
We can, sir. You can proceed.
Yeah. Yeah. So thank you to all. So today's my talk is on imaging for cochlear implantation. I did my name is Manu Sruth. I did my, one second, something stuck here. So I did my PG in Manipal and then did my fellowship in implantology in CMC and then had a brief stint of training in US under Dr. Balcony. Currently, I'm working as a consultant at Yashoda Hospitals. So why do we image in cochlear implantation? So main thing, the first primary thing is to determine the candidacy, because radiological candidacy is very important apart from the level of hearing loss which the patient has. And then for surgical planning, and also to select the side in which side you want to implant in case of a unilateral CI. And in some centers, the CT is studied extensively to determine which electrode length has to be used for a particular patient. And also we can predict outcomes of a patient if they have got anomalous cochlea or other radiological findings which will affect their outcomes later. And coming to the candidacy related to the radiology only, otherwise, so the contraindication to CI is the absence of the cochlea and absence of the cochlear nerve. So absence of the cochlea can be detected in both MRI and HRCT, but regarding the nerve, only the MRI can give an indication. So sometimes always a question comes up, should we do both? Should we do one? Which one should you do? So if I would say you want to do only one imaging, then MRI would be the choice for the simple reason being that you can assess the cochlear nerve. Otherwise, if you're planning a surgery, it's always good to get both the MRI and the CT done. So imaging is not only for preoperative imaging, but it is also for intraoperative these days and also for postoperative assessment. The main modality for imaging which we are using are, at least in most of the centers and where I have trained also, we are using both high resolution CT scan and also the MRI, preferably 3 Tesla if available. So CT basically gives us the bony anatomy, the bony labyrinth, the cochlea, mastoid middle ear, the anatomy of the facial nerve, and it's more of an indicator for surgical planning. Whereas the MRI gives us a picture about the membranous labyrinth, the fluid in the inner ear, and the status of the nerve, and the general condition of the brain, the auditory cortex, brainstem, and other areas. So, when do you image is a big question in all of our minds. When you get a child or an adult with a severe to profound deafness. So, if you get a child with congenital deafness, it is advisable to get an MRI done at least to know what is the status of the inner ear. Depending upon the age of the child or the facility in which you are, if you have the facility for giving general anesthesia or sedation and get scanning done, then it is advisable to get both MRI and CT done if feasible. And in patients with acquired hearing loss or postlinguals, you can do an imaging only when you're planning for a CI. Otherwise, usually you can go with a trial of hearing aids and then decide on a CI. And it is always necessary to get it done prior to hearing aid fitting in congenital deafness. Then comes the acquired cause, which is the post-meningitis hearing loss. So this is like a auditory emergency for implantation. So you have to get both HRCT and MRI done, so that we can decide the candidacy and intervene for an implantation as early as possible. And we would discuss regarding this in the further slides. So to obviously study the imaging, you should have a very clear-cut 3D anatomy in your mind, and you should be able to imagine the anatomical structures in all the planes. Coming to the HRCT temporal bone. Coming to the HRCT temporal bones, can you guys hear me? There's some change here.
We can hear you, sir.
Yes, sir, we can hear you, sir.
Okay, so coming to the HRCT temporal bone. So the high resolution means that the cuts are usually less than 1 mm, which is usually 0.625 or 0.7 in most of the centers with 0.3 mm intervals. And when you see a HRCT, when the data is reformatted, it is important that you're able to see the lateral semicircular canal like this complete in a axial cut. if it is tilted or in one cut, you don't see the entire lateral canal, that means the reformatting hasn't been done properly. And similarly, in the coronal plane, you should be able to see the superior semicircular canal like this, a straight line in one cut, which indicates that the formatting has been good. Now, usually axial views are mostly important for us in an HRCT, and we usually read it from superior to inferior. So most of the talk will be based on the importance of reading the HRCT for your surgical planning, and also regarding details about the cochlea and candidacy and all. So I would not just jump into the cochlea right away. So there are a lot of other things which you need to consider in the initial part. Like usually we need to see the thickness of the parietal bone. This is the parietal bone, and this is your mastoid. This is the suture line, the junction called the asterion. And usually we elevate the periosteum from this suture line. Either we make a pocket here, or we drill the bone to make a well for the CI receiver stimulator. So depending upon the thickness of the parietal bone, you will have to make a well. So depending on the device also, your well could be anywhere from 1 mm to 3 mm, depending on what device you're using. So when we study the CT, it is important to identify the thickness of the parietal bone. You will see something like this, which indicates, this is like a suture line, which indicates your asterion. So above this, you can determine the thickness. You can measure, if you have a PAC system with you, you can easily measure the width, and you will have a clear-cut idea whether you can make a good well or not. Then the other structure is when we make a flap, and posteriorly when we are elevating the flap, sometimes there can be a very prominent mastoid emissary vein, like in this image, which is connected directly to the sigmoid sinus. So if you are not aware of this and you keep on elevating your posterior flap, then there is a chance you may end up injuring the vein, having a lot of bleeding and causing problem during the initial steps of the surgery. It can be controlled easily, but it will become a mess in the initial part. So this is something which is important when you're reading the scan. Next thing which we look for is the mastoid pneumatization, which is, of course, it will determine how well you can do your standard mastoidectomy. So you'll have either a hyperpneumatized or a diploic mastoid or a normal pneumatization. And in acquired cases or patients who have had history of otitis media, they can be a sclerotic mastoid, which may be a bit difficult during the implantation process. And there is another thing which is important. Just ignore this arrow. This image is not mine. So in a pediatric temporal bone, because the pneumatization has not completely occurred, you will see a lot of zones which look like this, which are neither pneumatized, which are or not like thick standard bone. So this is basically like a bone marrow, and this can cause a lot of bleeding in very young pediatric age groups, like 1 year or less than 1 year, because of when we keep on drilling to make access, these areas can just keep on bleeding and cause significant loss in much younger children who have got around 7 to 10 kg body weight, 1 year olds. So this is something which has to be noted on the scan. The next thing is corner septum, which we identify, and we can, this is basically the suture line between the petrous squamous and the petromastoid part. So you have to go through the corner septum to enter the antrum. Usually the corner septum is, not usually, it is lateral to the incus. So you have to go through this to identify your short process of incus. And to assess the way your mastectomy is going to go, you have to identify the borders, how your sigmoid sinus is, whether it is anterior, posterior, or sometimes there is bulging too much into the mastoid cavity, which can cause an obstruction for your access to the round window to the facial recess. And also assess the height of the tegmen, whether it is low, or low means it could be, almost at the level of the dome of the superior circular canal, or even lower than that. So this is a low tegmen. Then next comes the middle ear. Basically, when we are assessing the middle ear, you have to see whether there is air, whether it is normal, or there is a otitis media is persistent in the young child. See the structure of the ossicles. So I won't go too much in this detail in this. It's not very important. Ossicles, we all know we have the standard ice cream cone appearance. The only importance of the ossicles here would be normal lying incus, the short process of incus is an indicator for your facial recess. So you have to make sure that this is present in the normal position or not. Now, coming lower down, the next important part is identification of the facial nerve. Because some of the congenital anomalies or cochlear anomalies can cause a low-lying or an anterior-lying facial nerve, which can cause problem during a facial recess. So this is the intra-auditory canal, and in the uppercuts of the intra-auditory canal, you can see that the facial nerve, the labyrinthine segment is over here, and this is the first genu, and then the horizontal segment starts. So this is something which you have to identify and see whether the anatomy of the, and then the same horizontal segment has to be traced towards the second genu, which will be somewhere over here, and then you trace it lower down as the vertical segment, which helps in assessing your facial recess. And then you also have to see whether the facial nerve is dehiscent or not. And these are some of the signs like snake eye signs. This is the labyrinthine and the tympanic segment of the facial nerve. And this is the tympanic segment, which is just related to the lateral canal. It is, they call it like a pear from the tree sign. So these are just fancy names, not much important for us. The next thing is the measurement of the facial recess. So after you have identified the facial nerve, usually the facial recess is measured left side. This is the facial nerve, the vertical segment, and usually the face, it is very difficult to identify the chordotympanic nerve. So the width of the facial recess is usually taken from the facial nerve to the extra-auditory canal or the annulus, bony annulus, and this is usually taken at the level of the round window niche. So this is the round window niche, because this will be your axis. Your axis will be like this towards the round window niche. So usually this is the level at which we measure. If you go lower down, it will be much narrower, and if you go higher down, higher up near the short process of the incus, it will be much wider. And usually at this level, the facial recess would be around 3 mm, which is adequate. Anything less than that may cause some trouble during approach to the round window. And also you have to see how the facial recess is, whether there is a cell over here, the facial recess cell, or it is there's total bone over here. You can assess that on the scan, and which will give you an idea when you're actually drilling and proceeding with the facial recess. Next thing which you have to identify is the round window, also on the axial cut, and you can see whether there is a false membrane present or not. Sometimes if there is ossification, it usually starts at the round window at this level, because this is where your cochlear duct opens, and you can see some whitish bony deposits here in early stages of ossification. So this has to be identified. If there is a too prominent lip or the niche is too prominent, then you will be ready that you have to drill the niche more probably to identify the membrane. So these are a few things which you have to see. I won't go into the details of sinus tympani, it's not very relevant for us. Then the other thing is, apart from the round window, you have to also make a note of where the oval window is, if there is any otosclerosis, and if the oval window or round window is atretic, if there is any round window otosclerosis. And in some of the bony diseases like Paget's disease, this is how the picture appears. And in osteogenesis imperfecta, you can have like this, like a halo sign kind of thing in these bony disorders, which can cause sensorineural hearing loss also. Now, when we see the facial recess, we try to take a trajectory. We draw a line going through the facial recess towards the round window, and it can give us some idea whether the access will be okay or not for round window bar cochleostomy insertion, which may be easier, which will also depend upon the how the cochlea is located, whether it is rotated or not. So we shall talk about later. Sorry, some problem is there. The next thing is we should also assess the status of the jugular bulb. If it is a high jugular bulb, which is Usually, if it is till the level of your basal turn or round window, we call it high. Whether it is dehiscent or not, it can cause problems when you're doing a round window insertion. So it has to be made note of. Then also you have to make a note of the internal carotid artery, which you will usually see at the lower level along the basal turn of the cochlea. And why this is important is, it is important if it is a case of labyrinthitis ossificans and we are doing a drill out procedure and we're drilling the basal turn of the cochlea. Then if we keep on going anteriorly and do not limit to around 8 to 9 millimeters, then there is a chance that you may enter into the internal carotid artery. So that is important. And also you have to identify if there is any dehiscent or an aberrant internal carotid artery. The next important thing is the internal artery canal. And you have to identify the internal artery canal and see how at a lower cut, how the inferior vestibular nerve and the cochlear nerve is dividing. So this is the inferior vestibular nerve, this is the cochlear nerve, and it is entering through a kind of a bony defect here, which is called the cochlear aperture. And then this is the modulus over here, this whitish gray structure. So these are the structures which have to be identified. You can see thin bar of bone radiating from the modulus, which is the osseous spiral lamina. The internal artery canal can be or narrow. Usually a dilated internal artery canal is not very significant. It doesn't read anything, but a narrow internal artery canal can be an indicator of a hypoplastic cochlear nerve. Now coming to the most important structure, cochlea. So if you are actually not doing a surgical planning and you are not a CI center, but you have imaged the child and planning to refer, then the one main thing which you are supposed to see in the CT scan is this, which is the cochlea. So you have to see whether the cochlea is there or not, and if it is present, whether it is normal or abnormal. So usually you can see all the three turns of the cochlea. This is the basal turn, this is the middle turn, and this is the apical turn. So you are supposed to see the size, whether it is appears normal or not, whether all three turns are present or not. And you can also make out the interscalar septum and the modulus, which I showed in the previous cut, and also identify the cochlear aperture. And cochlear duct length is something is measured when we plan for an implant. And on a coronal plane, this is how the cochlea looks. It's called the snail sign. So this is what I was mentioning, the cochlear aperture, which is usually around 3 mm. Anything narrower than that indicates a hypoplastic cochlear nerve. Sometimes the cochlear aperture is totally ossified or there is a bony bar over here. And when you do an MRI, there is a good eighth nerve, good cochlear nerve. The cochlea appears normal, but the cochlear aperture is narrow. So these children may get implanted, but the prognosis could be bad. So this has to be picked up, because otherwise just a fly view you will think that it's a normal scan. Now something about the cochleovestibular anomalies. I won't go too much into detail. This is the classification by Levent Seneroglu. So there is a Michael deformity, cochlear aplasia, common cavity, cochlear hypoplasia, then incomplete partition defects, and enlarged vestibular aqueduct. This is the classification given by him and widely followed these days. So Michael's deformity is where it is the most severe malformation. There is a complete arrest of the entire cochleovestibular apparatus. So you don't see anything over here, and this is an absolute contraindication for cochlear implantation. So you just see in this image there is the facial nerve at the first gene over here, and then it is following. You don't see any cochlea here or any vestibule here. So this is a complete contraindication. Next is cochlear aplasia. In this, you may have a rudimentary vestibule, but no cochlea. So this has to be differentiated from a labyrinthitis ossificans. So if you don't have a good history, you may get confused, because if there's too much of ossification, you may not be able to identify any cochlea. But you can see a bulge over the promontory, which is usually absent in a aplastic cochlea. Then a patient can also have a common cavity deformity, which usually looks like this. There is a single cavity. You cannot identify a vestibule or a cochlea separately. and usually there will be a wide IAC. You can expect perilymph gusher in such cases. The next anomaly is the cochleovestibular hypoplasia. Basically, it looks like a normal cochlea, but the size of the cochlea is much narrow, is much smaller. Cochlear aperture is much smaller, and there may be a dilated or hypoplastic vestibule may or may not be present. Now coming to the incomplete partition defects, which are basically three types, type 1, 2, and 3. Type 2 is the most common, not most commonly, but among the three. This is the Mondini's deformity which we see. In type 1, there are no interscalar septa and there is no modulus. Type 2, there is a cystic apex, basically the middle turn, and the apical turn, there is no interscalar septum, so it forms a cystic apex. And in type 3 deformity, interscalar septa are present, but there is no modulus. So these have to be identified. So in incomplete partition defect type 1, it looks there is a vestibule, and in the uppercut this is the cochlea, and there are no interscalar septae seen over here, just like smooth walled cavity. This is the type 2 where you see a cystic apex, Mondini's deformity. It is also associated with a dilated vestibule and enlarged vestibular aqueduct. Usually, patients with Mondini's have good compared to other deformities. Now, coming to the X-linked deafness or the IP3 defect. In this, you can see clearly there are interscalar septae present over here. This will also have a IAC, wide IAC. There is a perilymph gusher in this. So, this is something which is trying to prevent so that you can anticipate the gusher. Enlarged vestibular aqueduct syndrome can be seen with either Mondini's or patients with Pendred's. The vestibular duct is wider more than 1.5 mm. So there are many classifications for this. But normally a vestibular aqueduct just looks like a very thin line, maybe a 1 mm, or sometimes it appears like just a dimple at the end, at this bony petrous part. But if it's something like this, then it is an indicator of an enlarged vestibular, vestibular aqueduct. And this red arrow is indicative of the posterior semicircular canal. So usually at this level, you will see the and same thing can be read even in a now the deformities end there. Now regarding a note on labyrinthitis ossificans. So patient with meningitis, as I said, you have to do an CT and an MRI. CT will basically pick up any ossifications, and MRI would pick up any early stage fibrosis which is not showing any fluid in the inner ear. So this ossification has been classified by Balcony with C1, which says there is difficult to differentiate between the endosteum and the basal turn. It looks like this one layer. And C2 is there is definitive narrowing of the basal turn, and C3 is there is complete bony obliteration. You don't see anything. So this is something which has to be identified preoperatively. So this is a C3 where there is complete ossification, and you can see on the MRI there is no fluid at all. Like this is the normal side where there is fluid intensity, but here there is no fluid level at all. So this is a very difficult case. Probably you'll have to do a drill out procedure to put in. Now there are two other structures which are important to be identified. This is the cochlear and the vestibular aqueduct. This is the cochlear aqueduct. It is usually parallel to your IAC, and you can pick it up at the level of the basal turn at the round window. It opens just near the round window and opens into the perilymphatic space, stellar tympani. And so whenever there is meningitis, this is the path through which infection can spread and cause ossification. And usually ossification starts around the round window niche and then progresses proximally into the cochlea. And the other thing is the endolymphatic duct or the vestibular aqueduct. This one is perpendicular to the IAC, and this is much higher. You will see it in much upper cuts somewhere near the posterior semicircular canal. So this is how a normal one looks, or they may be just a dimple. You cannot even identify this. So this is something which is important. And then there are a lot of anomalies, not anomalies, but variations of normal seen with the vestibular or superior semicircular canal. Sometimes the lateral canal can be dilated like this with a very small bony island, and but these patients may have a normal cochlea. So not much has been attributed to the vestibular anomalies, and usually these patients, because it's a congenital thing, they may not even show any vestibular problems. So if the cochlea appears normal, it should be okay. Now, note on surgical feasibility. So after you have read all this, there are a few papers which have commented about the axis of implantation. Like this paper is actually by Dr. Satyakiran, where we have calculated the angle of the cochlea through the basal turn along the mid-sagittal plane, and determined the angulation. Like if the cochlea is too anteriorly rotated, then it is easier for round window. You can be seen. If it is posterior, then you cannot see the round window. So sometimes through the facial recess approach, you cannot identify the round window, and you may end up doing just a cochleostomy and putting your electrode in. And this paper is by Dr. Neelam Vaid and Dr. Manoj, where they have identified few lines. One is along the posterior external canal, and the other one is along the sigmoid sinus. So they say if your basal turn lies in between, basically this is your axis of your microscope. This is how the light will, go through your microscope. So, and your facial recess is here. So if your if your basal turn is lying in between these two lines, then your light will focus. You will have a straight axis, and favorable anatomy. But something like this, either two anterior sigmoid or a two sloping posterior canal wall, then you cannot directly probably visualize the basal turn of the cochlea if it is lying outside, and this becomes a unfavorable anatomy. Similarly, posterior canal wall line along with the line going through the basal turn. If it is parallel, it's a favorable anatomy, and if it is crossing like this, then probably the cochlea is rotated, and it is a difficult anatomy for school. Now, if you take a special, if you ask a radiologist to do a special reconstruction, then you can calculate something known as the cochlear duct length. It is basically the length of the cochlea from the helicotrema till the base, so that you can calculate the length of electrode which you want to use, usually offered by Medel, variation of length of electrodes. So you can calculate this by using this formula, 4.16 multiplied by A minus 3.98 in millimeters. So A is the distance, the largest distance from the round window, and this line is passing through the modulus to the lateral wall of the cochlea. So this is A. This can be calculated to determine the length of the cochlea, and eventually deciding which electrode you would like to place. Now, before I go to MRI, just one second. Before I go to MRI, I would like to just run through a scan, and then I will take some questions on CT, and then we will progress to MRI. So, is this, can you see this?
Yes, sir, we can see.
Yeah. So, just one second. So this is a HRCT of a 2-year-old child with deafness. So what I was saying, so I'll just run through what I just talked about. So this is the parietal bone, and if you keep following this suture line between the squamous and the parietal, it will come and reach a very like this odd area with a bony suture line, which is the asterion. And just above this, you can determine the thickness of the bone. And as we keep going down, I'm reading the right side. And yeah, so this is your superior semicircular canal over here. And as we keep going down, we follow the superior semicircular canal, anterior and posterior crus. And the next structure, as you are reading, you will also see the pneumatization, that it is very well pneumatized. So probably it will be an easier case. And this is the posterior semicircular canal. You can see the intra-artery canal coming in over here. And then if you follow over here, it divides into the facial nerve and the superior vestibular nerve. The facial nerve, here you can see that was somewhere here is your first genu. And then if you keep following the facial nerve, this is your horizontal facial nerve, you keep following it, keep coming back, and just a cut below the lateral canal. If you keep following this one, this is your facial nerve, and you can keep following this till you reach the round window. So you can see that the cochlea came here. This is your facial nerve, and this is your basal turn of cochlea. This is the round window niche area, and somewhere here, I think this is a bit angulated the scan. Somewhere here, I would measure the the facial recess. So this is the facial nerve, and this is where your posterior canal is almost starting. This would give me the width of the facial recess. There is a good facial recess cell. You can see that here the posterior canal wall is sloping like this. So in a lot of pediatric cases, the wall is sloping like this, and this can sometimes become an obstruction. So we take off the lateral end of the wall to give us access to the facial recess. And you can see the false membrane of the round window here. And whenever you are reading the cochlea or any anomalies, the first thing is to identify the intronatory canal, and anything anterior to it is the cochlea. Anything posterior to it is your vestibule. So the first turn which appears is the middle turn. This is the middle turn of the cochlea. And then if you keep going, so this is the cochlear aperture, modulus, osseospiral lamina. And if you keep going lower down, then you will see all the three turns. So apical, middle, and basal turn, and this is a round window. And we'll see if we can identify cochlear aqueduct, cochlear duct. So we can't make it over here. And yeah, this on the other side you can see. On the left side, this is the cochlear duct over here. This one. You can see that it is much lower, and it is parallel to the IAC. And if you go much little bit higher, then we'll see if we can identify the vestibular aqueduct. So I can't make out in this scan. Sometimes it would be just like a dimple, and you can't see the duct actually. This is a posterior sensor canal. So it could be just this dimple over here. So sometimes it is, or most of the times you can't see. Then the other things are your regular ossicles and promontory and all this. And yeah, so this is about the CT scan. I would be happy to take any questions now, and then we would go to MRI.
Hi, Manu. Yeah, good ones. A question from Munish from Jaipur. You had a slide on pediatric CI, right? So you want to know whether it is the marrow which we have shown or cochlear cleft.
So that's what when I was showing that, I mentioned that ignore the arrow because I picked it up from Google. So that arrow which was there was for cochlear cleft, which is like not a ossified part of the cochlea, usually seen in pediatric age group. But I wanted to show the marrow in that, which was posteriorly. So rightly pointed, and as I mentioned during my presentation, so I would just go back to that slide if possible. Yeah, I can take the next question. Till then, I will go to the slide.
Yeah, Monish is happy with the answer. One question from Suresh, Dr. Suresh Kumar. Can singular nerve groove be seen?
A singular nerve can be seen. I think it was there in one of the images. Let me just.
Will be available on a coronal section.
Yeah, even on in this one it is there. Like wish as a. Yeah, so you can see over here. This is a singular nerve. So you can see even in the axial cuts and also on the coronal cuts. I don't have a coronal cut showing that. We can try in the image which we have. I'll try to get that image. Till then, we can take the next question. Any other question?
Manu,
Yeah.
if you permit me, I can show the singular now. Is that okay?
Yeah. Yeah.
Can you share the screen?
Yeah, I have shared the screen. You can take.
Yeah, just a minute.
Hmm.
Okay. Yeah. Yeah, are you able to see the screen here?
Yeah.
Yes, got it?
Yeah.
This is the one. Right?
Yeah.
Everyone here?
Okay.
Seen?
Yes. Yes.
Yeah, I'm just taking off this.
Okay.
Yeah, you are on.
Yeah. Any other question? Any significance of noting the? I can see the question here. Any significance of
Yeah.
noting the depth of round window membrane? Yeah.
Yes.
So if the bony niche is there is a big overhang and you see a false membrane, then it will be a you can predict what you will see in drop. I don't think there is any other significance regarding the depth of the round window membrane.
One question from
Going for a round window insertion, so the depth would not actually matter.
Manu, one more question from Dr. Anil. He wants you to emphasize once again on facial recess approach from outside. So he wants a trajectory.
Yeah. I don't know if I can make a trajectory on that this thing, but I will.
Okay.
Yeah, so if we so in this image, like I said, this is the facial nerve, and this is where your round window membrane is. So we can draw a line from here, like this. There's no line on this, so but we can draw a line from here.
Yes.
Take on the annotate thing.
You can do it.
Yeah, I got it. So you can draw something like this. Oh, sorry. So my hand is shaking. So you can draw a line like this and come out. And basically this will tell you, how much your posterior canal may be obstructing, if there is a sigmoid sinus bulging. So it gives you just a brief idea of how you can approach the case.
You can actually ideally measure the length.
Yeah. So you'll know the depth, how much depth the round window is from the facial nerve. So
yeah, a few more questions have come up. What is the narrowest and the plastic part of the cochlear nerve on MRI in IAC?
This is the narrowest and a plastic part of the.
I don't know what exactly is plastic mean, but what is the narrowest part of the cochlear nerve on MRI?
It is where it is entering the cochlear aperture probably, but I don't know. And I show it on MRI. Then I can see the questions here.
Yeah. Is there any numerical figure to a narrow and widened cochlear aperture? I think 3 millimeters is for a narrow IAC.
Yeah, it is 3 millimeters for narrow and 9 millimeters for wide. But usually above 9 millimeter wide usually has no significance. But narrow one is definitely significant. If you have only a CT, you can predict that this person may have a cochlear nerve hypoplasia.
To my knowledge, IAC's diameter should be 4 to 10 millimeters plus 2 millimeters plus or minus. So that should be measured exactly at a midway distance between the porus acousticus and the fundus.
There is another question which has come here. Is there any consideration for trajectory for? I am not well, or I have not done this technique, but I think the trajectory does not matter because in Varia technique you have already pushed the electrode into the middle ear, and then you are putting it into the round window through the external auditory canal. So I think there is no consideration of trajectory or even the intracochlear trajectory. All that is has no. I think it is not probably considered in Varia, but I'm not sure because I'm not done.
Can you show the site of cochleostomy on axial section?
Yeah. Okay, we'll just put the screen on. So this is the image, and this is your round window membrane, and so cochleostome will be little bit just anterior to the round window, somewhere over here, but it is very difficult to tell on this axial cut. I think probably on a coronal cut it is easier to identify, but it is somewhere over here, just anterior to the round window membrane.
Okay. One question from Dr. Sidhu. Will CT help in selecting a round window approach or a cochleostomy route?
I think if you are able to identify the rotation of the cochlea, you can probably, and you can draw that line through the facial recess, you can probably decide whether round window will be, anticipate, not decide, but anticipate if it would be easier or not. But obviously the indecision will be on table itself. So I won't say that you should make up your mind pre-operative.
One question, is there any attempt made for navigation or image guided electrode insertion?
Yeah, it has been done. There is a group, I think in Austria or somewhere, I'm not sure, in Europe somewhere, and which is funded by MEDAL. So they designed a software which reads the CT scan, and then they put the navigation, and they get they do a robotic cochlear implantation in which the narrow tunnel is made from the mastoid cortex right into the facial recess, and it also makes a cochleostomy and the electrode is inserted. So I'm not able to recall, but it has been done.
I hope that question can be answered when we go ahead and do a presentation on a recent advances of cochlear implantation.
Yeah, I think Monish has answered Switzerland group. Okay.
Yeah. One question, I don't know from who has put this, but I think they want something about the aplasia part.
Yeah, so cochlear aplasia, I put an image there. Though, so basically, you won't see anything. You will just see a facial nerve in the 7th, 8th complex, and you don't see any cochlea. You don't see a promontory bulge in the middle ear. So nothing will be there.
Yeah. Can I ask one question?
Yeah.
Now, we were talking about the cochlear aqueduct. You said that it actually opens near the round window. Actually, it opens a little bit 6 millimeters away from the round window membrane.
Okay. No, but it is connected to the perilymph, right?
Yes, exactly. Undoubtedly.
Yeah.
Yeah. One question. What is extended round window approach and when do we go for it?
So basically, when you are not able to do a proper round window insertion because of whatever angle difficulties, then you start with a cochleostomy, and then you can proceed posteriorly and open the round window membrane and do an extended round window approach.
Yeah, basically between a round window and a conventional cochlea.
Yeah. I think imaging won't help you do that. These are something beside interop.
Okay.
I now proceed to the MR.
Yes, please go ahead.
We can take the other questions.
Yeah, Manu, please.
Sorry, I'm just fast forwarding. Yeah, so coming to the MRI, so general info, you can do a 3 Tesla if available, but even 1.5 is good. And the most important sequence for us is the heavily weighted T2 sequences, which are depending upon which company the MRI machine is. They're called different thing, Drive, Fiesta, or Sys sequences. So you have to mention when you order the scan that you need a heavily weighted T2 image along with a sagittal oblique reconstruction of the IAC so that you can identify the nerve complex properly. So this is what a heavily weighted T2 image looks like. Basically, you can see the CSF which is lit up. Basically, all the fluid is lit up, and the black part is the nerves. So here you can see the inferior vestibular nerve and the cochlear nerve going into the modulus, and you can identify the fluid intensity in the cochlea, and also you can identify the spiral lamina. This blackish part is an indicator of osseous spiral, and you can see the lateral canal here. And on a coronal image, this is what it looks like. So you can compare the fluid intensity between the two cochlea. If you are, if it's a case of ossification, then you can compare and also make a decision if you're planning for a unilateral implant. MRI can also pick up deformities like a cystic cochlea or ossification, as I told you, where there is no fluid. You can also pick up CSF leak. The mastoid may be full of this hyperintense fluid. So these are some things which you can pick up. And the most important thing is the 7th-8th nerve complex. So in an axial image, you can make out the facial nerve. In the upper cuts, you'll see the facial nerve, and behind you'll see the supravestibular nerve. But as you go lower down, you will, like in this previous image, as you go lower down, you can see the inferior vestibular nerve and the cochlear nerve. You can also see the thickness over here. And so you can rely on this image for determining whether the cochlear nerve is normal or not, because sometimes you may not get the sagittal oblique images. When you go to a sagittal oblique, this is what sagittal oblique means through the IIC. And this is what the contents of a normal IIC look like. So they call it baseball in a glove appearance. Here is the facial nerve. So this is anterior, this is posterior, superior, and inferior. Sorry. Just 1 second, coming soon. Yeah. So this is your facial nerve. This is a cochlear nerve, superior vestibular nerve, inferior vestibular. Usually the cochlear nerve is either same size as facial nerve or maybe more than that or same size. But anything small, lesser than the facial nerve diameter indicates cochlear nerve hypoplasia.
Manu, can you just opt for a laser pointer, please?
Yeah, I am not able to get it on my existing. Yeah, there's some problem, so I'm not able to get it. Yeah, so let's continue. And you can also see in this image, you can see an absent cochlear nerve. There's just a facial, superior, inferior vestibular. Or sometimes you can see entire absent 8th nerve and only a facial nerve over here. So there is some classification given by Castleman et al. Regarding the nerve problems, vestibular nerve. So A7-8 nerve complex. So the first type 1 vestibulocochlear nerve aplasia is where only facial nerve is present and the entire 8th nerve is absent. Type 2 is there is some problem with the vestibulocochlear nerve. It is present, but there will be some issues. So in type 2, the first one in that is the undivided nerve. So you'll see a single bundle. So these, I don't know, you can do a cochlear implant, but prognosis would be bad. Then the type 2B is where there is a superior vestibular nerve, inferior vestibular nerve, and there is a absent cochlear nerve. And the last one is all 4 nerves are present, but it's a hypoplastic cochlear nerve. And these details can only be studied if you have this sagittal oblique view. You can actually measure the diameter. We had very good 3 Tesla MRIs in CMC in fellowship. So we could see this properly, we could measure, and we could see the dimension. So if you have a 3 Tesla, then it is very good. And then of course you can see the general architecture of the brain, like CP angle if there are any tumors for acquired hearing loss. So that's about MRI. And the next thing is intraoperative imaging. These days some centers are doing using a C-arm for guiding the electrode in common cavity deformities to see how the electrode is going or other deformities. Coming to post-implant imaging. So usually we do it just after surgery or the next day to see how the electrode is. You do a lateral oblique view. If it is a bilateral implant, we do a Townes view or a transorbital view. And if the image is a clear digital image, you can count the number of electrodes. And if you're able to get the shadow of the cochlea, you can also count how many are in, out. So those things can be done. And post-operative, post-implant CT is usually done when either something has gone wrong in the surgery or you are not getting post-op, the ECAPs are not good, potentials are not good, or at a later stage, the child is not performing well. You suspect that there is maybe some issue with the electrode, either the electrode is ejected. So if there is any red flag, then a CT can be done to study or if there is a complication post-op. MRI is usually not advised, but now there are devices which are MRI compatible. So usually we do it for other reasons, maybe head trauma or some other neurological issue. So there are these special views where you can count the electrodes and do a lot of studies on this, how the electrode is placed. So routinely we don't do it. So the key fact is, for anybody, you have to able to identify a normal cochlea on CT and identify a cochlear nerve on MRI. So if this is done, we can do a good candidacy, and child can be, or the adult can be referred, or implant can be proceeded. But without doing this, just putting a hearing aid for a profoundly deaf child and continuing him on it is not justified. So some kind of imaging has to be done. Yeah, so thank you. I'm happy to take questions.
Very thanks, Manu. This is a great lecture. I'd like to request the audience to put their questions into the chat box so that they can be posed to the speaker. Questions, please.
I can see a question: radiological criteria for CI.
Yeah.
I think the only radiological criteria is absence of cochlea or absence of the cochlear nerve. So these are the exact contraindications. But apart from this, I don't think so. If there is a cochlea and there is a cochlear nerve, you can implant. So
I would say presence of an implantable cavity, not necessarily be cochlea.
Yeah, that's what. Yeah, correct. I can see another question. Can you please speak a bit about the facial recess abnormalities seen on CT scan? So facial nerve, there is no facial recess abnormalities. If there is a anteriorly lying facial nerve, then your facial recess may become problematic or narrow, because of course there will be a cochleovestibular anomaly or any syndromic child. The course of the facial nerve may cause problems. There's no abnormality, but maybe variations of the normal. If it is there is full bone, sclerotic, or there is there are no cells in the facial recess, then some things you can anticipate.
And somebody wants to talk to you about the physiology of the hearing.
Can you tell the correct accepted
physiology of hearing? It's actually a mixed theory.
You can use CT to demonstrate it.
Yeah. Brainstem evaluation needed if auditory brainstem implantation is considered.
Yeah. So if there is an absent cochlea or absent cochlear nerve, then it is advisable to do a brainstem implant. Like in today's date, a poor result with a cochlear implant is better than the best result of the brainstem implant. So even if you see a hypoplastic cochlear nerve, or you can do a electrically evoked potential and plan for a CI. But even then, if you're going for a brainstem implant, you have to assess the brainstem on the MRI, and usually we see the distance between the third nerve nucleus and the eighth nerve nucleus. We see if there is any lesion over there or any atrophy. So that can be something which has to be considered while planning a brainstem implant. This is all theoretical, no experience. So
yeah, somebody was trying to ask something about the alpha angle.
I don't know what is alpha angle.
Maybe the angle between the mid-sagittal section and the line which is drawn along the long axis of the cochlea of the basal term.
Okay, so maybe for cochlear rotation or something.
Yes. One question regarding the concept of physiology of hearing. It's actually the mix-up of von Beckers's and place theory. That's for
how it demonstrated on CT.
Yeah.
Is it
contrast MRI supposed to be done?
The MRI which we showed is not a contrast MRI. It is your regular MRI, but you have to ask for a heavily weighted T2 sequence. If you do a routine MRI with T1, T2, you will not get this sequence. And you can pick up the nerves on other normal T2 also, but it won't be so clear. even though your radiologist will report it as normal, but if you want to do a detailed study, then I would advise you specifically ask for this when you order a radiology.
Enlightened about cochlear rotations and precautions.
I think you can tell better on that because you did your paper on it.
Yeah. See, what we are talking about the cochlear rotation is actually the anterior rotation or the posterior rotation. Why? Because we are studying the axial sections. So here we'll be able to comment on whether it is anteriorly or posteriorly related. But at the same time, we have to think about the superior rotation and also the inferior rotation. That can be studied better in a coronal section. So it's always the three-dimensional view which you need to think about, that is better understood by a three-dimensional reconstruction. Okay, did I answer your question?
And basically, you can anticipate whether you will be able to do a round window insertion or not. So that's the thing which you will obviously decide intra-op itself, but you can just anticipate it.
Yeah, and with the new techniques like a Buckman's technique, we can always do or almost always do a round window insertion in most of the cases.
Details of okay. I think thanks a lot to everybody. Thanks to the moderators, my senior Dr. Satya, and the organizers. I think the organizers can take over. They will tell about the the next schedule of present.
Thanks, Manu, and thanks to everyone over here, and special thanks to Dr. John Matthew, who has been our director when we have done our fellowship. Thank you, sir. Thank you very much. I take the opportunity to thank you. Thanks to the organizers. Harsha, can you take over, please?
Yes, sir. Sir, thank you very much, sir. Thank you for the great talk. It has been a great response. We are getting good response in the WhatsApp also. By that, we want to tell you that tomorrow there are two webinars conducting. One is by Dr. Manoj Agarwal, who will be talking about HRCC of temporal bone regarding familiasis and pathologies. Following that, this is from 4 to 5:40 p.m. And following that, there is a talk by Dr. Akshay. He is from HCG Oncology. He's going to talk on lasers. In the first part, he's going to talk on lasers, the basics on lasers, how to set up and how to make your setup, and what are the basic things you should know to bring the patients to it and how to deal with them. And followed by the detailed malignant as well as benign cases of how to operate on laser on head and neck diseases. So with these things, we will conclude this. If anyone still has any doubts, there are numbers given below in our flyer. You can message us or contact us directly for anything.
Two questions. Can we take two questions, Manu?
Yes, sir, sure.
Yeah.
So I can see one which says, when do you decide second turn insertion? So basically, when you see the CT and read the ossification, so there are different grades of ossification depending upon how much the cochlea is ossified, whether it is a basal turn, middle turn, or entire 360 degrees. So if your entire basal turn is ossified and going up to the middle turn, not fully, you can see and decide for a second insertion. But but I think it is more of an intraoperative decision. Make a tunnel in the basal turn or directly go for a second turn.
Okay. Second question is, what is Buckman's technique?
I think you can answer that.
Okay. So when your facial recess is very narrow and you are not able to access your round window membrane and the round window to go ahead and do a round window approach of electrode insertion, what you can do is you first thin out the canal wall, the posterior canal wall, and then you can make two vertical cuts superiorly and inferiorly to the extended posterior tympanotomy side. Then you move the bony canal wall or push the bony canal wall anteriorly without elevating the skin or without disturbing the canal skin. So you are enlarging the posterior tympanotomy anteriorly so that you can gain access to the round window or the middle ear there. So that is called as a Buckman's technique.
There are a couple of questions coming on the surgical aspects. We have a talk for that. So I think all these techniques and how to do a second turn cochleostomy, everything will get covered in that. So
The landmarks for second turn cochleostomy, is
yeah,
it?
so,
Would you like to answer or?
so it's basically just inferior to your process cochleoformis and anterior to the oval band, I think 1 mm. So
Yeah, that's it.
Sir, I think that marks the end of today's webinar.
Great, thank you.
Here are the details of next series, part 3, surgical anatomy for cochlear implantation. The topic will be presented by Dr. Satya Kiran. It's on April 24th. Right, sir?
Yes, yes.
Yeah, so see you on 24th. Again, the timing is the same, 4 to 6 p.m.
Yeah. Thanks, everyone.